Welcome. Today is November 26, 2024. Today is SEVA VentRounds, and the question is too much support. And again, we're focusing today on reading the waveforms. The disclosures is there's no endorsement of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. And here are our disclosures for myself and for Rob, which are conflicts of interest. You can see that the pressure is constant during inspiration and the flows, each one of the flows is different. Very good. And then CSB means that every breath is spontaneous. And I would ask the team, what's the definition of spontaneous breath versus a mandatory? Anybody wants to put it on the chat or unmute themselves and tell us? Excellent, Sami. Triggered by the patient and cycled by the patient. And we know that these ventilators are a little bit funny because it changes colors, but you can see the S up here, which stands for a spontaneous breath, which tells you that it was triggered by the patient. There's some deflections on the pressure waveform. You can see the flow changing and crossing the baseline. And then you can see that it's cycled by the patient, by manifestations of the patient because of the peak flow to the end expiratory flow, and the inspiratory flow. And so you can see those different types of breath. There's a question from Rob. How do I know that it's not IMB? That's a good question, Rob. Just by looking at this, and I would say it's hard for me to define that just by looking at the waveforms. I'm cheating by looking at the mode down here, unless you have something that you know extra there. Rob?
Yeah, it's you would need to know the inspiratory time of those long breaths. They look like pretty much the same inspiratory time, but if you'd have to calculate what they were for each one or measure them or something.
Yeah. But
if they were all exactly the same, then that would be your clue, right?
That could be one of the clues. And one of the challenges always is to try to do that on the fly, right? So trying to tag a mode on and I know that Samit sent me a video, but this is the most representative image that I took, Samit. It was not lack of love, it's the same thing, it repeats. But I would say that it's impossible for me to make that decision just by this waveform itself. So I have to go down to the bend mode app and look at what we have read and learned from the manual, correct?
Yes, Eduardo, something else, the fact that there is no respiratory rate set implies that there is no mandatory breath rate.
Yeah, that's a possibility, although I would argue that what we have learned recently with IMB type 5 is that some of these breaths could turn into mandatory, and it's not because of the basal rate. It could be that the breath turns into mandatory. But I think that those are subtle the differences that I would say that in general, if I would send people with the home messages that use the bend mode app or any of our cards to look at the tagging that tells you the truth about the mode. Does that sound fair, Rob?
Yeah, I think that's the only way to do it. And that's a good way to learn how to do it too.
Yeah, because and the other one is to grab the card, get the ventilator, go into a room, connect it to and then see how it interacts. That's another way to do it, separate from a patient. But it's adaptive, and I think that there's a little bit of a clue that this is adaptive. And when I was looking at this, you can see the different heights on the pressure, and obviously this is a slanted image. But I could see on the video that there was a little bit of a difference, and the goal is that they're trying to get to this tidal volume of 540. All right, so that's adaptive. So the ventilator is going to move up and down to achieve that tidal volume. All righty. Yeah. All righty. Good question. So what is the load? So what do the team feels is the load? Elastic, resistive, or PMOS? Or is the PMOS hiding everything? All right, I'm seeing some answers come in. There's one for PMOS. Anybody else? Okay, so let's just talk a little bit about this. I see a good amount of, there's a resistance there. Yeah. So there's some features that are suspicious for high resistance. Some features, I would say. And remember, this is 0, 1 second, 2 seconds, 3 seconds. So it's a scale of 1 second. But look at the breaths. There's 3 very long breaths, and you can see that the system pressurizes. There is evidence of perhaps PMOS, perhaps the patient is taking a breath in, but it goes for a long period of time. You see, it doesn't reach baseline during those 1.5 seconds. And then when I look at my expiration, I see those deflections, but then it takes a fair amount to go to baseline. I don't see it going back to baseline. And although that can be expiratory work, it could also be that there's increased resistance. So I think that I agree that there's evidence of PMOS, but I would put a potential for resistance there. And I would be highly suspicious for increased resistance on this patient. Rob?
I would agree with that. And here's another little tip. If you look at the volume waveform on those 3 big breaths, it's a nice, smooth exponential curve. And the reason for that is when you integrate flow to get volume, integration takes away some of the noise. So the noise that you see in a flow waveform might make you think, well, there's a PMOS in there, and there might be, but it's not so obvious when you look at the volume waveforms. It doesn't seem to be distorted by PMOS as much.
That's awesome. I love it. Yeah. So in other words, the volume kind of filters and amplifies the signal from the flow. So sometimes that's you can see it as a surrogate or not a surrogate, like the cousin or the mirror image, but amplified, like those mirrors in the hotels that amplify your face. All righty. Very good. So now let's go to the PV discordance, and as always we start in order. So what's the if we start by trigger, what's the trigger? Normal, early, late, false, or failed?
How do we know what the trigger signal is on this vent?
Well, I don't know. But at least it doesn't point it out on the screen, right? It just tells you that it's on spontaneous breath because it's red.
Yeah.
But I don't know if it highlights elsewhere that it's using a pressure or a flow trigger like other ventilators do.
Right.
Anybody knows if it has any marker? Right. So I see some people said normal, and and Samin sees 1 failed. I would say that I probably see a couple more than 1 failed. But let's take a look. Let's walk together through all of them. So remember, when I'm controlling pressure, I like to look at the flow. So I see here evidence of PMOS. You see how it moves from baseline up. So that's evidence of PMOS, and then it triggers. And actually, I'm going to amplify for a second. Every time I do this, I mess up. But you see how the pressure goes down there, and actually over here too. And look how the flow goes up, which is consistent with evidence of PMOS. And so that's one. And so I would say that trigger maybe late. I mean, you could argue that this is late. And I would probably say that's right. It just takes a fair amount, but we don't have any way to do it. So if you say it's normal to your eyes, that's okay. But I see it dropping from here all the way to here, from here all the way to here. You see how long it takes for it to trigger? So I would say that these are probably late triggers because there's a fair amount of time for them from the moment that the pressure and the flow start changing to it activated. So I would vote that these ones are late.
But there's an argument against that though, Eduardo, because the patient is breathing in while he's breathing out. That's why it takes a long time to get to zero. So it's not the ventilator's fault, right? The ventilator can't be faulted until the flow crosses zero. And then if it takes time, then the sensitivity isn't set right.
Well, but without a doubt, but if you have this patient on NAVA,
yeah, that's true too.
So the truth is that the breath started probably over here, right? That's where the inspiratory effort, and it took all this time. But you're right, the ventilator is triggering when the signal got crossed.
Yeah, but you're right. You know, as we always say, the truth is the patient signal.
Yeah.
The patient signal is reflected in the flow, even if it starts, you know, during the expiratory time. So, yeah, I guess you're right. Strictly speaking, it's delayed triggering, but it's not something you could fix, right? On this ventilator at this point in time.
In this case, and then you have this one over here, and that's probably what Samin saw. This is the first one.
Yeah.
Then you have another one here.
Yep.
Then you have another one here, right? And those three in this signal tells you that this patient is triggering, and so he's failing to trigger. So this helps you actually a little bit, perhaps, to start thinking about maybe the resistance is actually increased, right? This patient is taking a while to trigger, and it has an amount of failed triggers in there, and that's concerning for increased resistance. So usually when I see a signal that is consistent with resistance, a late trigger and a failed trigger, I would say this patient has auto PEEP until proven otherwise. That's one of the suspicions that I would have. And so the one that you have to fix first is your triggering issue. That's one of them, because after that, if you go and try to read this, you could read this as, so let me pause for a second and ask a little bit about inspiration. Do you think that this patient is assisted, over-assisted, or under-assisted? And Ariel, I presume that you meant failed trigger, not false triggering. Yeah, so I like your way of thinking, Arcel. I mean, this is a little bit challenging for us. And I'm going to say why. There's some literature about over-assistance in which you give a very large tidal volume and then the patient fails to trigger because you have given too much tidal volume during that breath. So it could be that this patient is over-assisted, and then it's not triggering because you're giving too much tidal volume, and that's generating some air trapping, and that's why the patient cannot trigger. Or it could be that the patient has intrinsic PEEP, auto PEEP, and then you're under-assisting the patient because he has so much auto PEEP, so you cannot assist them during that breath. So this is where I'm having challenges on how to classify. I mean, this would be technically a patient that has auto PEEP to me, and I would not put him as over assistance. However, you can see patients in which you have given too much support, and this is happening. So probably the proof is in the pudding, and Samit can tell us if they went down on the tidal volume and this actually corrected and the patient started breathing better, or if they treated the auto PEEP and the patient got better. That's the two pathways here, Samit. So why don't you guide us a little bit here?
So here, I think being in the patient's room was very important because the patient was struggling to even catch a breath. She was trying to pull, a week before I came on, they had tried APRV, the patient was on assist control, and I kind of changed the patient to volume support just to gauge on what's going on before we could do some interventions. And the waveform, although I agree with the failed triggers, I really felt strongly that there was a resistive load. Now the patient had been on bronchodilators and steroids, so I didn't thought there was an intrinsic airway resistive load, but there was some resistance, especially like how the flow waveform in the expiratory phase sort of just flat lines before going to baseline. So I thought there was a fixed resistance somewhere. and the flail triggers pointed towards auto PEEP, and the patient was just really struggling to get air despite getting decently high tidal volumes. That and the slowness, the slow nature of like how long it is taking for the flow to generate the volume made me think she's under assisted with fail triggers and a resistive load. That was my initial assessment when I saw this patient, because she had like very high use of like extra respiratory muscles just to get with each breath. So there was a lot of PMAS, I thought, because the patient was under assisted due to the resistive load.
Yeah. And what was your next? So if we think about this patient now, that I mean, there's several features that the team is talking about: increased resistive load, right? And it could be intrinsic because of bronchospasm, or there's a ET tube narrowing, or the tube is against the wall, or something along that nature. Or it's a small ET tube. So I guess that the question now that we have seen this, what would be the next strategy for management for this patient if the goal is comfort? And I presume that was the goal, is trying to get her to interact. So what would be our alternatives? There's some late trigger, and there's failed triggers. What are the options that we're thinking on? So Arsel, the question about what's the sensitivity of the trigger, and that's a good question. I mean, it would be important to just ensure that this is not a pressure trigger, and so that we are not seeing that this is because it has to reach that threshold to trigger. But I presume that this was a flow trigger just based on the flow waveform and how it's crossing the baseline. It taking a while, and then it crosses and it activates the breath. So it would not change if you make it more sensitive, because it's taking a lot of effort from the patient to cross the zero baseline. So changing the threshold would not necessarily activate or solve the failed triggers or the late trigger on this patient in particular, Arson. There's another question, another option here is to test decrease auto PEEP. And so to start going up on the PEEP to try to decrease the amount of airway resistance. So kind of splinting the airways and decreasing the excessive dynamic collapse, and getting the patient to be able to, and that's something that you would do and see if the triggering solves as you start going up on the PEEP. That's another good option. Then the next one I see is, put the patient on pressure support. Essentially, that's what the CSB with pressure support. And the aim there probably would be to minimize the tidal volume and allow the patient to trigger, but with less tidal volume. And that may be an option, is to, sometimes we are giving so much tidal volume that is creating more air trapping on this particular, but it seems to me that based on what I'm listening, this patient had a very high work of breathing and it was unassisted. So that may not patch out. Lee suggests NAVA, and NAVA, I would say that's a great option for this patient, perhaps because of the delay, the late trigger and the failed trigger and the resistive load. There's a challenge on how to activate, but you don't have that on the PV840 or PV980. That's a mode that it's only available on the servos at this point. Rob justifies that too. Any other thoughts, Rob?
No, I think we covered it.
Yeah, I think that the key here is you have to decrease the auto PEEP and the resistive load, and so perhaps a bronchoscopy is in place, or to assess the airway and where it is, an assessment of why the bronchospasm is not giving up. And sometimes it's just time, and let the patient support them while they're there. But these patients are at high risk of prolonged mechanical ventilation. We know that the presence of failed triggers, either due to over assistance or to under assistance in the setting of auto PEEP, that is related to prolonged mechanical ventilation. Really good case, Samir. Challenging, I can imagine, especially because the triggering with the technology is going to be very hard to achieve. What was the, do you have outcome on this
Yeah.
patient or?
So we thought of two things. One is dynamic airway collapse. So I immediately went up on the PEEP to 10 and 12 to see if that takes care of it. Unfortunately, the expiratory wave still showed that sort of slow flow resistive. She was still having hard time breathing. And that is when and she had a 7/0 tube and she was a big lady. So we decided let's like look in the, take a bronch and see. And we found like the posterior end of the tube sort of like buried in the trachea, with phlegm sort of stuck, sort of so the outlet of the ET tube was kind of partially open. And that's why I think the flow, especially in the expiratory phase, was kind of like stuck. So we replaced it with an 8/0 tube. And while she was paralyzed for the bronch, we did some fresh mechanics. And with the new tube, her intrinsic PEEP was 0.6 and her plateau was 19. So I think that, and now she's awake, off sedation, off pressors, MAP of 100. She's still a little weak, so requiring somewhere between 16 or 14 of pressure support, but otherwise, good outcome at the end of the day.
Excellent. So your diagnosis by the waveforms led you to doing a bronch and improving outcomes on the patient.
Yeah,
Hey.
and one of my fellows here have a question, and Rob, you or Eduardo can go over it. We use sometimes E to IE sync triggering and cycling in these ventilators, and they are wondering, is this like a regular flow trigger? And how, like, you have the percentage by peak flow cycling in our usual pressure support, but how does the E to I sync work in the PB980s?
That's a good question. And I'm not sure I can give you an accurate answer right now. It looks at several things. I'm not sure.
So
Yeah.
that's great, Samit. We have something to look at. Actually, one of the crazy things with this is that sometimes these algorithms may lead to either false trigger or early cycle, or they may lead to changes in how the mode behaves and change a mode from a mandatory to a spontaneous or to an IMB just by activating one of these automatic synchronization features. So really, I mean, it may be good, but we need to understand how they work, right? You just made a perfect question, which is what are we calculating? And from there, you can define what's the right place and the right patient in which you want to activate that button or not activate that button.
Yeah, I think that mode was activated out of panic because they couldn't like ventilate the patient, and they put every of the features of the ventilator turned on to see what's happening. and I think that's why before I started intervening, I got the video so I wanted to share it with you and the group. And thank you for the wonderful analysis. We really enjoyed it.
I love it. I think so. So just this is the Satoshi moment. Satoshi is one of our fellows and asked for us to start doing this, and so we honor him. So the key findings was the increased resistance, failed trigger, late triggers, and that led you to considering what's the cause of the resistance. We're treating this. Let's take a look with the bronch that revealed an ET tube that was obstructed, leading to changes in management and solving the problem. We also talked a fair amount about what are the alternatives to deal with this. And we talked about modes of mechanical ventilation, changes on PEEP, changes on sensitivity, as well as NAV as a potential opportunity. I want to thank all of you and essentially wish you all Merry Thanksgiving and a great time for all of you. We appreciate you. Here's how to contact. Use the email is the best way. Resources, prior episodes. This is episode 82. And we really appreciate you all and have a great day. Thank you, Samir and Jefferson team. Looking forward to working more with you.